So coming to the clinical steps in composite restoration, local anesthesia is given if needed and the preparation of the operating site is done, followed by shade selection, isolation using rubber dam, cotton rolls, gingival retraction cords or preoperative wedging. Coming to the tooth preparation, the conventional design. Conventional tooth preparation are those typical for amalgam restoration. The walls are in butt joint junction with the restorative material. Indications are preparation located on the root surfaces, moderate to large class 1 and class 2 restorations. Coming to the beveled conventional preparation, it is indicated when a composite restoration is being used to replace an existing restoration exhibiting a conventional tooth preparation with enamel margin or to restore a large cavity. Outline form has external box-like walls but with some beveled enamel margins. This design is typical for class 3, class 4 and class 5 restorations. Coming to the modified preparation, it is scooped out preparation. Modified preparations are indicated for the initial restoration of smaller cavitated and carious lesions, usually surrounded by enamel and for correcting enamel defects. Coming to box only preparation, this design is indicated when only proximal surface is faulty with no lesion present on the occlusal surface. Coming to the facial or lingual slots, this design is used for restoring proximal lesions on the posterior teeth. Coming to shade selection, composite shade is selected by working with a clean, moist tooth prior to placement of the rubber dam. The shade selection should be done prior to prolonged drying of the teeth because dehydrated tooth becomes lighter in shade as a result of decrease in its translucency. Samples from the shade guide should be applied parallel with the tooth whose color is being matched, not in front of it. Because if we place in front, it will appear lighter and also not behind it. Because if we place behind, it will appear darker. Shade is selected according to the manufacturer's shade guide or Vita shade guide. Natural light is preferable. Shade tab is holded near the teeth to be restored and is partially covered with lip or operator thumb. Coming to the isolation of the operating field, rubber dam is used for isolation. Cotton rolls also can be used with or without retraction cords. Coming to the restorative technique, the preliminary steps for enamel and dentin bonding. Both the liquid and gel etchants are available, which is almost 37% phosphoric acid. Acid etching is done for about 15 to 13 seconds. Following this, it has to be thoroughly rinsed with the water spray for 15 seconds. Later, the surface should be dried with air or cotton pellets. The etched enamel appears frosty white. Coming to bonding, use of low viscosity resin which will flow into etched enamel pores and dentinal tubules to form resin tags. It acts as intermediary between tooth and the composite. The bonding agent is applied using a micro brush. The manufacturer's instructions are followed regarding the number of coats to be applied and the curing time, usually 20 seconds labially and lingually each. It penetrates the irregularities on enamel and bonds micromechanically by formation of resin tags. On dentin, it penetrates the collagen network and the dentinal tubules. Coming to curing, two categories of technique are commonly used in curing polymers: continuous and discontinuous. Continuous curing. The continuous cure refers to a light cure sequence in which the light is on continuously. There are four types of continuous curing: uniform continuous cure, step cure, ramp cure, and high energy pulse. Continuous curing is conducted with halogen and laser lamps. In uniform continuous curing, intensity is kept uniform over the time. In step curing, intensity is increased in sudden step over the time. In ramp curing, the intensity continuously increases over the time. In high energy pulse, the high intensity is kept for shorter exposure time. The discontinuous cure is also called soft cure, which commonly uses a pulse delay. The distance from a tooth to initiate a cure and then moving it close to the restoration for the duration of appropriate exposure. Insertion of the composite. Composite can be inserted with the help of hand instruments or syringe or guns. The materials is inserted in increments in thickness of 1 to 2 mm. Different designs of increment placement. 3 increment design. One flat increment followed by 2 oblique increments is placed, both at proximal and occlusal box. First increment should be thinner than 1 mm. Vertical layering technique. Increments are placed in vertical fashion. Increments are placed in vertical fashion, starting from one wall and carried on to the another wall, and curing is done. Horizontal layering technique. Small increments are placed horizontally, one above the other, starting from gingival wall to occlusal wall. Oblique layering design. Each increment is placed obliquely, starting from any sides, and curing is done from all 3 sides. U-shaped layering design. At base, both gingival and occlusal, U-shaped increment is given. Repair of the composites. Old restoration. Etchant, primer, adhesive and composite is used. It has a bond strength of 50%. Freshly polymerized. If not yet contoured, directly we have to place the composite. If contoured and polished, we have to re-etch, we have to apply the adhesive and then the composite. Tunnel restorations. Jinks in 1963 introduced this as a conservative approach for class 2 restorations. Hunt and Knight modified the technique. Coming to the indications, it can be indicated for cases where there is high aesthetic demand, and in cases where there is low caries rate with small proximal caries without the involvement of the marginal ridge. Contraindications are large proximal caries involving marginal ridges under excessive occlusal loads, and which are difficult to access. Coming to the advantages, the marginal ridge is preserved and reduced micro leakage is seen, adjacent tooth is preserved. Coming to the disadvantage, poor visibility and lack of caries removal is seen, marginal ridge may be undermined, preparation may extend closer to pulp than desired. Coming to the sandwich technique, it was developed by McLean. As we see in the picture, we apply a layer of GIC and then the composite. It is also called laminate or bilayered technique. Large class 3, class 4, class 5 and even class 1 and 2 cavities can be filled using sandwich technique. Closed sandwich technique. In closed sandwich technique, the GIC is placed over the pulpal floor and axial wall, and then the composite is placed and cured on the GIC. Coming to open sandwich technique. In open sandwich, the GIC is placed on the gingival seat and on that composite is cured till the occlusal level. Advantages are the favorable pulpal response is achieved due to biocompatibility of GIC. Fluoride release minimizes the recurrent caries, and less amount of composite is used, so there will be less polymerization shrinkage. Coming to the disadvantages, it is time consuming, it is technique sensitive, and adhesion of the composite with GIC is weak. Thank you.